Tracy, I sent you the link.
Okay, just waiting to come through. All right, let me go test, make sure it's working.
Okay.
Yep, good to go.
Thank you.
You're welcome.
Miss Crystal, you have a quorum. You can start your meeting. Everybody's moved over.
Okay, well, we will go ahead and get started. And I believe the first order of business is to call the meeting to order. And I believe we need to say that. Is this where I need to say that if you have any questions, you can add it, Dr. Collada?
This is where you announce that if you have any matters you want to add, you have to add them before the executive session.
Okay.
Otherwise, once we leave for executive session, no new business can be added.
Okay. So we will go ahead and do introductions of everyone that's on the call. And I guess I'll just call everyone's name. I'll start with myself. My name is Crystal Chase Cercello. I'm a PA at Arbor Family Health in Maringouin, and I'm serving as the chair for this committee. And then I'm just going to read the names in order. Walt Green.
Walt Green with Phelps Dunbar, representing LAPA. Thanks so much for having me today.
And then Miss Berkeley.
Hi, Berkeley Durbin. I'm the lobbyist and director for Medicine Louisiana, physician membership organization, and I appreciate being included. Thank you.
Dr. Nikolic. Sorry.
Hey, I'm Aisha Nikolic. I am a family medicine physician at Ochsner, and here as a PA advisory board representative.
Varsha.
Good afternoon. My name is Varsha Castro Gussman. I'm the founding program director for Xavier University of Louisiana PA program, and also a practicing PA at Ochsner Health in the neuro ICU, and I'm a board member for the PA advisory board.
Dr. Van.
Good evening. I'm Van Collada. I'm the executive director of the State Board of Medical Examiners and a retired obstetrician.
Shelley.
I'm Shelley Esnard. I'm a PA and here in Baton Rouge and representing the Louisiana Academy of PAs.
Sarah.
Hi, I'm Sarah Deo and also representing LAPA.
Raven,
Hi, I'm Raven Lewis. I'm a physician assistant in pediatric orthopedics at Oshner Main Campus, and I'm a member of the Physician Assistant Advisory Committee.
Miss Bowen,
Good afternoon, Mariah Bowen. I am representing the Louisiana State Medical Society.
Miss Patricia,
Patricia Wilton, Executive Counsel, Chief Legal Officer for the Louisiana State Board of Medical Examiners.
Dr. Craven,
Hey, Jimmy Craven, vascular surgeon here in Baton Rouge. Also serve as president of Our Lady of the Lake and FMOL Employed Provider Enterprise, member of the PA Advisory Committee.
Lauren,
Hi, Lauren Sudeth. I'm an attorney here with the Louisiana State Board of Medical Examiners.
and Emily. Emily,
Oh, Emily, is that Emily Davis?
it just says Emily.
She may be on mute. She's a PA and in charge of the A at Oshner, New Orleans.
And then
Here's-
I think I missed Dr. Cresswell.
Hi, I'm Dr. Cresswell. I'm the Director of Investigations for the Louisiana State Board of Medical Examiners, and I'm an emergency physician by training.
Did I miss anybody else? Okay. I guess if we will continue, the next thing on the agenda is the approval of minutes from March's meeting. Did everyone get a chance to look at it? And if so, can I get a motion to approve that?
Motion to approve.
Do I have a second?
Second.
Are there any not in favor? All right, motion is approved. The next thing listed is the CDS CME verification.
Okay, let me take that because we have been remiss in our verifying that all of the PAs that are prescribing controlled and dangerous substances have taken a board-approved course. So what we want to do is send out a blast email to all of the PAs stating that if you prescribe narcotics, we have to verify your course. Please send us a copy of your course credit, and we'll verify that it was one of the board-approved courses. If it's not, you'll have to take a board-approved course. And if you're not prescribing, you have to apply for the waiver that says, I'm not a prescriber of narcotics, and we wouldn't require them to take a course. But that's a state law passed in 2018, and we have been remiss in documenting that. And you are the last group that we have not documented it on, and so we need to document it on you all. So with your approval, I'll be sending out that email.
Does anybody have any discussion or objection to that? Do you need a motion for that?
I
To
would
approve
certainly
that?
love it. It would be nice if you approve the motion to send to begin the process of verifying the CDS CME for all the PAs.
I have a quick question if I could ask.
Sure.
Is there a list available of the board's approved courses that can be taken? Just out of quick
Yes.
curiosity.
Yes,
Okay,
it's on the board's website. Yes, ma'am, it
Okay.
is.
perfect.
All
And
right.
for example, if you or your employer is insured by Lamico, there's a
Mhm.
Lamico approved course that you can take. If you or your employer provides the course, as some institutions do, like LSU, you can take that course and you would qualify. And then we have a list of other qualified courses, approved courses that you can take.
Thank you.
Yes, ma'am.
Is there a motion to approve the CDS CME verification?
I move to approve the CDS CME verification email.
Is there a second?
I second.
Okay, Crystal, pardon me, but before you vote, go ahead and ask for public comment before you vote.
Are there any public comments?
I'm checking right now. Give me one moment. None at this time, ma'am.
Is it okay to just ask if there is a against vote instead of having everyone voice?
Yes, if you ask all in favor and everybody says aye and you ask any opposed, then that will presume that everyone has made a voice vote at that point.
Okay, all in favor, say aye, please.
Aye.
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 I think that was about 5. Are there any opposed? Okay, that passes. All right. The next thing on the menu is laws and rules. And if y'all remember the long process that we have been going through since, I don't know, 2021, I believe at our last meeting, we decided that we would have Ms. Patricia meet with the LAPA people and attorney to really hammer out the specific language of what we want in the rules and the changes to be made. So for this, I'm actually going to have Shelley jump in and help me. And she did provide us, I believe she provided all of the members and the board with this information that we can go over. And most of this we have already voted on, and we can reference back to which meeting we voted on that. But I believe this is just to clean the language up. So at this time, I'm going to have Shelley go ahead.
Thank you, Crystal. And Walt, I didn't know if you wanted to start with kind of a bird's eye view and context around our relationship with Ms. Wilton and kind of how our work group went between, I guess it was late April till recently.
Sure. Yes, committee, thanks again for letting me address you today. On May 2nd, I believe the advisory committee authorized Patricia Wilton and I to start negotiating suggested or proposed language that LAPA wanted to see, and certainly update regs where they needed to be updated, in our opinion. Patricia and I have met on at least 2 different occasions. We have swapped red lines going back and forth with language and proposed language. As you know, we finally went to the LSBME board, where the board then directed us to come back to the advisory committee and try to break this up into organizational segments, which we've tried to do by utilizing a chart. So as we go down and we can go through, and Shelley will certainly explain 1 through 15 or so proposed changes that we have. And then once you had a chance to discuss it, or we can discuss over the rules, then we would just ask whether it passes or not pass. And that way we could feel like we fulfilled our mission to the board. So thank you for letting me address you again.
Madam Chair, I'm sorry, there's not a copy in the agenda for me to display.
Okay. Ms. Wilton, do you have a copy of that?
I do have a copy of it. I'm not in a position to share my screen. Olivia, can you share your screen? That's what I sent to you.
Oh, I'm sorry. I can
Okay,
stop.
Olivia, I'm gonna stop my share and you share your screen, Olivia.
While she's loading it up, I'll just tack on to what Walt said. We did work very hard. We sent numerous drafts back and forth trying to make things that didn't make sense, and trying to streamline some of the things that appeared to be duplicative, if not contradictory. And I think we made a lot of headway. I think the board will have more input when it gets to the board. So I don't want to represent to anybody that I had the authority or that I do believe this is the absolute final copy. I believe I can accept these as the working document to send to the board if you all choose to vote to recommend these changes. I don't want to be disingenuous with anybody and say I think this is this is going to be rubber stamped at the board level. I think this is a monumentally vastly better working document than we had in the past, and it will be refined with everyone's input. Of course, it will be refined to make it even better at the board level, depending on how the board directs us.
So while Olivia looks that up, for people that want to get onto the public display on YouTube, they can go to our webpage and find the link, click on the link, and it will take them right there. The link is on our webpage to the YouTube, and it is on a 20-second time delay. And otherwise, it's relatively accurate in time of what we do.
Patricia, is it the strike through with the different colors on it, or is it the?
No, it's the one I sent you. It was either Monday, maybe it was Monday, remember, or Friday. You asked me the document to send to them, and you said the colors, and I said, no, there's a newer one. Let me forward it to you.
That's what I thought. Just a second. I'm
Okay,
sure.
yeah, good deal.
And Patricia, while Olivia's doing that, I don't know, all of the advisory committee should have a hard copy as well as an e-copy of our kind of scorecard, that we were trying to keep everything concise and in an efficient manner for you guys.
Is it this one, Patricia? Is it the one you needed?
Yes. That's the not the strike through though, right?
This one is the strike through. You want the one without?
Oh yeah, okay, yeah, I see it now. Yeah, okay, that's it. Yeah, that's the one. Okay, so Shelley, if you want to drive, you can get started.
Okay, thank you so much. Issue 1 was a pretty simple one, updating the PA licensing / renewal related fees. I know at the last board meeting, there may be some changes anyway coming down the pipe. Our recommendation, there might have been a few fees that were incorrect, would be just striking through the fee and just putting something generic that would be appropriate legal to say, per applicable, whatever standing fees are listed on the state board's website.
Would it be best, as Shelley talks about these, for us to motion and vote on them as we go instead of circling all the way back?
If there's, yes, if no one has any questions and there's no public comment related to it, and it's what you think of as an easy fix or a technical correction, then I would go ahead and vote as you go along.
Can we get a motion to approve updating the licensing and renewal and board related fees as seen necessary by the board? Is there a motion?
I motion that we update the PA licensing and renewal.
I second.
Board related fees.
I second. It's Craven.
Okay, and now ask if anybody has if there's any public comment or if any of our guests on the Zoom want to comment on that provision.
Is there any public comment?
Checking right now. No, ma'am, no public comment at this time.
All in favor say aye.
Aye.
Are there any opposed? That motion passes. Shelley?
Second issue is changing on page 1 and 2, actually just 2, is removing the word certification and just using licensure, because we are licensed by the State Board of Medical Examiners, but certified by NCCPA, which is defined later. So there's just correction in terminology here.
Do I have a motion to change certification to licensure?
I move
Motion.
to change the language from certification to licensure.
Got a second in there while Dr. Craven said that. All in favor say aye.
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 Are there any opposed? And before, I guess I needed to ask for public comment. I'm sorry, I got really excited.
No, ma'am, no worries. There is no public comment at this time.
Okay. Are there any opposed? All right, that motion passes. Shelley?
Rule, issue 3, we'd like to update the rules. Once a physician assistant has been defined as a PA or a PAC, we'd like the future word throughout the document to be PA.
Have a motion to change physician assistant after it has been defined to PA.
I move to change it to PA.
Is there a second?
Second.
Everyone in favor say aye.
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 Are there any opposed? All right, that motion passes. Shelley?
Issue 4, we'd like the rest of the document, once supervising physician has been defined, the rest of the document where supervising physician is used to be SP.
Is there a motion?
Motion.
Second?
Second.
All in favor?
Public
say-
comment.
Public comment?
There are none at this time, ma'am.
All in favor say aye.
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 Any opposed? None opposed. That passes. Shelley?
Issue 5, clinical practice guidelines is kind of the standard accepted term for the written agreement between supervising physicians and physician assistants. So throughout the document, there is kind of language that says clinical practice guidelines / protocol, or clinical practice guidelines or protocol. We would like it to just say clinical practice guidelines across the board and delete the word protocol.
Motion.
Okay, can I ask a question related to that? And it's only because I don't know the answer. Is there also a thing called protocols that are used in the practice of physician assistantship? I mean, clearly there are clinical practice guidelines, but are there not protocols as well? And I don't know the answer. That's why I'm asking.
Well, I think Sarah would be able to comment, because when we say protocol, it depends, I guess, mostly on the care pathway, and it depends on what you're treating. So, the clinical practice guidelines is going to have to be a little more available based on each practice site.
Right. So I guess I'm just wondering if there's a necessity. I'm merely asking, I don't know the answer, if there's a necessity to eliminate a reference to protocols, or just merely make sure that everyone understands that the clinical practice guidelines define the relationship between the SP and the PA, but that the PA may also be working according to protocols. If that's true, I don't know if it is or it isn't.
I don't know that that's true.
I would say that guidelines define protocols. So if you're working within the guidelines, then you can work in a protocol.
Okay. Great.
But I am not a native English speaker.
Berkeley does have a question.
Liar, liar, pants on fire.
Miss Berkeley.
Thank you. I did ask that several of the physicians in my organization take a look at the document that was provided to the board. So I don't know that I have all of the specific documents being presented here. I did reference chapter 15 when I was reviewing chapter 45, though I don't think that's one that was originally online here. Specific to the issue at hand, I was told that there was a distinction between the clinical practice guideline and the protocol associated therewith. I appreciate that the way that this rule is written and the way the definition is written and the way that those terms are used interchangeably throughout both 15 and 45, it certainly would benefit from clarity, although I would espouse maybe not eliminating the term protocol entirely, but simply distinguishing when you are asking for the protocol versus when the clinical practice guideline is what you wanted. Or do you want to include protocol in your definition of the clinical practice guideline? So just drawing a distinction between those two concepts.
But it's a protocol to what?
So typically you'll have a protocol to treat, again, based off of evidence-based medicine or guidelines. So for instance, if somebody comes in with a pulmonary embolus, there's a protocol you follow, yes, no, to determine whether or not they're going to get thrombolytics. That's why I said a protocol that's built off of guidelines.
As I understand it, the PA practices and is based on the agreement with their supervising physician, and that agreement comes with the clinical practice guidelines. Now, I agree that, we follow, there may be a protocol that the organization that you work for has set forth, but that doesn't necessarily determine the level of supervision that you're getting between the PA and the SP, or the SP and the PA. That is specifically coming from the clinical practice guidelines. And that's been my understanding. I don't know if anybody has any comment to that.
Yeah,
So,
this is Sarah. If I could just interject, I think what Berkeley's point is well made. The way it reads currently, it looks like we're referring to clinical practice guidelines and protocol or protocols interchangeably when they're not necessarily the same thing. And I think what Dr. Nikolic is really referring to is more of a standard of care, acceptable practice. And so we were really trying with number 5 to simplify that we're referring to the legal requirement that defines the relationship between the SP and the PA and the types of things that they do in that practice, in which case could be as detailed as that group sees fit, defined by statute, that the practice of the PA and the mode and mechanism of supervision is at the practice level. So it allows some flexibility, but it makes that clinical practice guideline document sort of where all of those things live, if that makes sense. That's how we're interpreting it.
Ms. Bowen?
thank you. And I'm sorry, for some reason, my little hand is not working. What was said to me was that perhaps there is a secondary definition for the term protocol, but you separate the two. And I think that's kind of what Sarah may be saying as well, that you have occasions where there are separate protocols that can be contained within your clinical practice guideline. So there may be a need for a distinguished set of two. And that's probably what Berkeley was saying as well, or something like it. I try not to speak for my lawyer, though, and she usually is my lawyer.
Are there any other comments or questions? Okay. Can we do a vote of simplifying the term clinical practice guidelines and not having those two to be interchangeable? Is there a motion for that?
Well, my thought is we've now brought up the questionable definition. So until we know what the definition of protocol is, I don't know that I can vote.
So we'll just table and pass over this one and move on, and then we'll bring back clarifying language that distinguishes the two next time.
We can table that.
Somebody needs to move that. Move to defer, move to table. Yeah. Okay.
Is there a second to table that motion?
I second it.
All in favor of tabling, discussing the clinical practice guideline protocol?
Aye.
Aye. Are there any opposed? All right, we will table that motion and go to the next one.
Okay, issue 6, as long as this document has probably been around, it says a PA must be 20 years age for licensure. It is now a master's degree, and it's unnecessary to have in this document as a minimum age requirement.
And if I'm not mistaken, you previously voted to approve the deletion of that language, but if you want to do it again for safety's sake, please feel free.
We did vote on that in February, but let's go ahead and have a motion to delete the age requirement.
Motion to delete.
Is there a
Second.
second? Are there any public comments?
The only public comment was how to find the link, and I answered that, and no, nothing on this point.
All in favor of deleting age limit, say aye.
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 Are there
Aye.
any opposed? All right, that passes. Next.
Before we move on, Dr. Collada, they were saying the link was not working, not that it was not there.
Ah, that's a different problem.
Yes, sir.
Tracy, are you still on the meeting?
I am.
Could you look into the link issue and make sure we publish the right one? Seems
Oh.
not to work. Could you check it out for us?
Is it the link to this meeting?
Yes.
I checked it before we started. I'll check it again.
Well, we're getting feedback that it's not working, so if you could make sure it's working, we'd appreciate it.
Okay,
Thank you.
you're welcome.
Okay.
All right, Shelley, you can move on to the next.
Sure. Next issue, we would like to eliminate the reference to core versus non-core competencies. There is no published list that exists with regards to core competencies. As a PA, it does create confusion, especially with onboarding, mostly emphasizing the experience and training of the PA and the qualifications of the SP, that they're within the scope. And currently, the current core competencies on NCCPA are, let's see, I had it written down, guys, a quick list. The current core competencies emphasizing the experience, knowledge of practice, interpersonal skills, person-centered care, interpersonal collaboration, professionalism and ethics, practice-based learning, and society and population health. So because this list, I mean, it doesn't seem that it creates any specific improvement to the document, or we just would like to eliminate core versus non-core competencies. And that is 4501B.
It should be in the red line document that you were given. Is there a motion to approve?
I motion.
Is there a second?
Second.
All in favor, say aye.
Public comment.
Public comment.
Sorry.
Sorry.
No additional public comment other than getting the correct link. You may proceed, ma'am.
All in favor, say aye.
Aye.
Are there any opposed? All right, eliminating the reference to core has been passed.
Hi guys, this is Lauren. I don't want to interrupt, but did we make sure that the public was able to see this meeting going on? Because I just checked the law and it says that we have to be recessed until the problem is resolved. If the
Okay, I
public,
just checked, and if they copy and paste that link, it works fine. For some reason, clicking the link on our website, I think it's more of a browser issue. But if they copy what's there and paste it in a new address, it actually works. I'm looking to see if I can post it a different way. This is how we've always posted it, and it worked before. But I've checked on my home computer and the work computer, both act in the same way. But if you copy it and paste it to a new website, it works.
In the meantime, I'm sending the public comment our Zoom link so that they can access it via Zoom. They're gonna come in just like our advisory members did.
I mean, if they copy and paste it, just send that link to YouTube, it comes up fine. They just can't click on it from our website. And I'm looking into that now. Trying to post it a different way.
Okay. That makes me feel a little squirrely about it, but I think that if they can still like access it, we should be okay. Since we checked on it, just hopefully we can get that resolved. As soon as
Thank you so
possible.
much for checking on that for us.
Of course.
Is it okay to move forward?
Yes.
All right, Shelley?
Okay, 4501E, we're asking to eliminate the maintenance of an additional credentials file. Mostly this is fairly redundant in our opinion with clinical practice guidelines, and it's created some significant confusion between, hospitals and private practice. And also maintaining this is adding some additional filing requirement annual signatures that really it's kind of overly burdensome, and our nurse practitioner coworkers do not have an additional credentials file. Everything we feel should go into clinical practice guidelines, and obviously, proof of training and everything else would lie there. Now, credential file for a hospital is going to be very different than one. So ideally, if we could have clinical practice guidelines and not have to maintain a credentials filing, then that will have to be done no matter what if you're working at a hospital system.
Dr. Van?
Ms. Shelley, do you envision that if a PA that's currently working in an environment, say like Ochsner, and has a clinical practice guideline, leaves Ochsner and then goes to work for me in my office, that the clinical practice guidelines and the privileges granted under them would then be the same, or they would be unique to my office and my practice?
So I think it would be unique to your practice site if they're not.
So then that PA now has a new set of clinical practice guidelines that she cannot apply the old set. So if she decides to moonlight on the weekend, or he decides to moonlight in an emergency room on a Saturday night, he can't use mine and he can't use his other ones. He has to have a new set for the emergency room. Is that correct?
Yes.
That's the way you envision. Okay, I think we're all on the same page. I
Yes.
just wanted to be sure we're all on the same page. Thank you so much.
Also, just so we know, we do have a new guest, Lauren, that's coming in right now.
Okay, we need to identify her. We're required to identify everybody on the Zoom. So she can
I just want to let
introduce.
you guys know the link is now working correctly.
Okay.
Okay.
Lauren's iPhone.
Patricia, it's Lauren Bailey.
Oh, hey. Okay, that's a representative from LSMS. We're all good.
All right. And Berkeley, do you still
Thank
have
you.
questions?
I do. And just for clarification, I appreciate your wanting to go through this through each of your amendments and proposed amendments and vote on them. The document that you're referencing online is not the same document that I had available from the board meeting last time. So there are some slight changes. I don't know if it is just too time consuming or if it would be appropriate to go through and register each concern or comment or question at every juncture. I want to certainly share that there are some general concerns. This may be the easiest time to do that because I'm looking at even back to your core competency comment. I don't know if the idea is to eliminate core competency language throughout the entire rule or simply in this section. And then now you've moved into, we went past the other changes under 4501B. So I don't know if you're just incorporating all of that into core competency discussion, and then now you're into the credentials filing discussion. If that's building in other places within the rule or not, that language was not eliminated in the previous iteration. So again, rather than just nitpick it all the way through, I wanted to share some general concerns. And then if something in the other sections, if something comes up, I'll just note that we have concerns. And part of the reason that I'm doing this is that we have participated in all of the YouTubes that were all of the advisory committee meetings over the last year and a half, but it was stated that there were no comments as this document moved forward. And so I just wanted to register our comments, but I don't want to hold anybody up.
Dr. Van?
Since we are readdressing the issue of core competencies, is there any value in the PAEA document that defines core competencies for PAs?
Shelley, I can jump in here. So there's actually two published documents related to competencies for PAs. There's a joint statement from the 4 large PA organizations, which is what Shelley was referring to earlier in the discussion about this. And those are really generic core competencies that are similar to your ACGME core competencies, interprofessional communication skills, practice-based learning, those types of things. And then PAEA has independently published core competencies for new graduates that are similar, but much more lengthy and much more detailed than the 4 organizations publication. What we thought that the group was referring to initially was years and years ago, the core competencies did encompass some procedural skills, suturing, incision and drainage, pelvic exams, etc. That's been done away with. So the discussions that we've been having over the last several months were really that those core competencies have sort of evolved into a much more generic, high-level, broad, sort of almost soft skills, people skills type things, not necessarily core medical clinical skill competencies. And it's created a lot of confusion for credentialing offices and hospitals. Like, what is the core competency? Well, we think suturing is a core competency, but we don't think that, say, a central line insertion is a core competency. So they're kind of having to make it up on their own. So it's really our assertion that a core list of skills does not exist, but that's what this was intending to refer to.
So to be clear, and we get back to what I asked earlier, the things that you may do, whether they be suturing, IND of abscess, pelvic examinations, collection of pap smears, or all those kind of things, you want to list them in the clinical practice guidelines now?
No, we would like the clinical practice guidelines to remain at the practice site with the SP. If he wants to list what he exactly wants that PA to do, then that would be up to each SP.
And whatever that SP defines, that's what you do, as opposed to utilizing the concept of clinical or core competencies, so that it would be basically you can only do in that practice what that clinical practice guideline allows you to do.
Correct.
Okay, then I think we're on the same page. I got no problem. I want to make sure we're talking about apples and apples and not peaches and pears.
Mm-hmm.
Okay,
Thank
is
you.
is it okay to move on to the next idea of the credentials file?
Yeah.
I believe Shelley explained it. Are there any questions or comments about the credentials file? Public comment before we go into motion vote?
At this time, there are no new public comments, ma'am.
Right. Can I have a motion on eliminating the credentials file for this?
Motion.
Is there a second?
Second.
All in favor say aye.
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 And if I might, just, you all know this, but just for the benefit of anyone who may be watching, who's not 100% keyed into all this, the fact that we're removing it as a requirement in the rules does not in any way prevent any employer of a PA from maintaining any kind of file that he or she wants. I mean, the bulk of the changes that we are making are to allow the relationship between a PA and an employer to be more tailored to their needs and more efficient in that regard, as opposed to having a one-size-fits-all set of rules that may have been appropriate in earlier times, but not so much anymore.
Is there any opposed to that credentials file vote? All right. I believe we can move on to the next one, Shelley.
Okay. We would like to, mostly for clarification, 4506C3, that PAs shall not treat or utilize controlled substances to treat chronic pain or obesity. Really, it needs to say PAs shall not utilize controlled substances for chronic pain or obesity, because PAs can treat it, but the treat or utilize is just needs clarification.
This is actually something we voted on back in February. Are there any questions or comments about it? We'll vote again. Public comments, Dr. Van?
No, none at this time, ma'am.
Can I have a motion to approve this?
I motion to
Is there a
approve.
second? All in favor say aye.
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 Are there any opposed? All right, that motion passes. Shelley?
Okay, and we only have 2 left, and we're only 45 minutes in, so we hope to finish this fairly quick for you guys. Second to the last is we would like to change the language really to allow for direct billing and reimbursement by government and private insurers that make it consistent with our APRNs and other advanced practice providers, PTs and OTs. And really that is 4503.
Now, I'll just point out, you all are free to do whatever you want, but we voted on this once before and it went to the board as your recommendation. So now you would be telling the board that you want to withdraw that recommendation and make a new recommendation.
Since we've already voted on this, is it appropriate to everyone just get a thumbs up and move on from it? Since I guess it's not a voting matter if it's already been voted on.
No, what you vote, this is not what you voted on. You voted on a different new language here that just said y'all can do whatever the agreement is between the PA and the employer. And we had a long discussion about why that satisfied everybody, and it made it as easy as possible, and it brought it to the contractual level between the employer and the employee, and everybody seemed happy with it. And apparently now they're not happy with it. So I just want to put it in context for you that you're going to need to explain to the board why you're changing your recommendation.
I wonder, Miss Patricia, if they didn't realize that had completely gone to the board, and that's why that was listed. Sarah, you have a question?
I'm sorry, I can't figure out how to raise my hand on the actual Zoom, the emoji hand. That's correct. So what was it voted on? I think this was in the December meeting, if I'm not mistaken. But what was voted on and approved only addressed the one piece of the billing side and didn't include the reimbursement side. So LAPA's official position was this still remains an issue for us. And if that's the final decision of the committee, then so be it. But this is one that we would continue to want to work on either through rule changing or another mechanism, because the entire issue hasn't been addressed. The direct billing is only one component of the issue, and the larger component is actually the reimbursement piece.
Well, let me ask a question, if you don't mind, Madam Chair. Wouldn't the contract spell out how you get reimbursed?
I suppose so. Would it be possible to
We can add reimbursement to that language and say any way that the supervising physician, his employer or corporate employer of the PA chooses to do billing and reimbursement. That would be fine with us. And I think we're trying to tailor this to all of the kinds of, look, there's still dyads of PAs and doctors out in Louisiana. We have to make sure that they're comfortable. There's large groups, whether they be Ochsner or Willis-Knighton or whatever, that they need to be comfortable. And for maybe the 10-man orthopedic group that has 9 PAs, they need to be comfortable too. And so I think that what we want to do is put a set of rules in place that address everybody, and even have to have different sections. But if we say that anyway, the supervising physician, his employer, or the corporate employer wants to allow you to bill and reimburse is sufficient to us, and we're comfortable.
Yeah, I mean, I think that was the intent, that to the extent that it allows for that to happen within the confines of the contractual relationship, that's great. If anything else, I don't understand, frankly, how it would work if, if the PA is not going to have an agreement with the employer about how money's going to be handled. I mean, I just don't know. I don't understand as I told Walt several times when we talked about it, I don't understand the work that it does. I don't have to understand the work that it does. And if the committee chooses to recommend that to the board, those questions can be asked again at that level. But I just, that was one that was dusted up on the shelf and it was already done. And somebody's going to have to be ready to explain why the first recommendation is being recalled.
Yes, it was brought up already. I missed that in my notes. And I think the intent across the board is the same. Sarah, if I remember correctly, I think one of we had was our PAs in the VA.
You cut out for a minute. What did you say, Shai? I'm sorry.
One of our issues that our VA PAs were having was with this. Was it federally?
Yeah, it says not the VA PAs. So I think it's two things. It's the original language referred to the section was titled compensation. And I think we are kind of confusing compensation of the PA with reimbursement by government and private payers. And we really here are just talking about insurance reimbursement for services. And the biggest issue is the PAs that are working in federal, well, there are only two that I'm aware of, and Crystal's one of them in the state that are working for federally qualified health centers. Because we are excluded from being able to reassign our benefits as the only advanced practice provider. We are not eligible for all of the reimbursement that is associated with working in those types of situations. Same with nursing homes. And so this is really, it's an employment issue, so that even if you are employed, which it's a barrier to employment for PAs and federally qualified health centers, but even if you are employed, because of this prohibition, you're not eligible for a lot of different reimbursement for carve-out services provided in those areas. And so this is one that is really pretty complicated, and we had offered back in, I believe, December to have an expert come in to provide some additional testimony, because we understand that this isn't, it's clinicians where we live anyway. This is really a business kind of issue. So I mean, we're happy.
And I feel like that should.
Mm-hmm.
I don't understand why that isn't handled at the business level. I don't understand how it's a rule for the Board of Medical Examiners. And
I agree 100%. And we would love to just delete it altogether. But the original language did say it specifically said PAs nothing shall prohibit a PA from billing for services. And so it's always been interpreted that PAs cannot be reimbursed because it's silent on that section.
Well, originally it said you can't directly bill for anything, and this was to cure that.
Well, we don't have time to pull that, but the billing issue was just one component, like I said, but the bigger issue is the silence on the reimbursement part. So I think we would be happy to have it removed from the rules altogether, but without it being mentioned somewhere that, that's allowable, just like it's allowable for nurse practitioners, physical therapists, occupational therapists, medical psychologists, that would have to be a legislative change. So we were hoping to avoid that and address it here so that we remedy the entire issue. The other point I wanted to speak to Dr. Vance's concern is that came up about the languages drafted in December was, if we include language that states that this has to be at the approval of the supervising physician or the hiring entity, that does potentially create administrative burdens on the business office of each entity in terms of, well, how do we know, is this service, was this individual service approved or was it not? Is that a blanket approval? Does every charge that's dropped have to have a modifying code to, to go with it? So there were some concerns raised from other members of LAPA that what had been approved sort of conceptually in that last meeting would create administrative unintended consequences that may be too difficult to manage. So this may be another one. I don't know, Shelley or Crystal, maybe we want to table and come back to and keep hashing it out. We certainly don't want, the board to think that we made progress, but it wasn't completely addressed. And so we're just trying to keep it, in the discussion and the dialogue so that PAs can be afforded all the employment opportunities that an APP can be eligible for. So,
yeah. Dr. Van, do you have your hand raised?
Yes, ma'am, I do. I would like to comment that in my some 46 years of private practice, I worked as an independent private practitioner. I worked in a small group. I worked for a hospital. I worked for Ochsner, a large group. And I will tell you that they tell us how they want things coded. They tell us what codes we're allowed to bill. And it is their determination really that's going to make the difference and not anything you put on yourselves. Because quite frankly, for example, even today at Ochsner, an Ochsner doctor cannot bill for the recommendation of marijuana. They don't allow it. It's just period. It's over. Okay. And I know Aisha's pulling her hair out by the roots, but we know that that's really what it is. And so the employer is going to make those rules. And if you want to talk about, are we talking about the doctor and the single dyad that might be in Bunkie, Louisiana? We'll talk about that. And I'm happy if you want to have your expert give me a call and we'll go over and look at the codes of concern and we'll try and figure out a solution for them. But I can tell you, I ran a billing service for 8 OBGYN practices, and each one of those practices had their own rules about how billing would be done. And that's how it's going to happen, I think, anywhere you work these days. But again, I'm happy to address your concerns if you let me know the specific concerns, and I'm willing to meet with your consultant if you like me to.
Well, we appreciate that. And I think in lieu of time, I agree with you both that this is just to stay on the record. I wouldn't recommend moving to any sort of vote since, like you said, we've already brought something up to the board, but maybe we can continue as long as you guys and all of our friends on this call understand the intent of our question with regards to this. I would like to just move on if possible.
Can we get a motion to table this topic?
Motion to table.
Is there a second?
Second.
All in favor, say aye.
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 Are there any opposed? Okay. Shelley, you said you had one more you wanted to talk about.
Yes, and the reason I know that some of the members on the advisory committee got my little follow-up list and y'all worried I skipped some, but it's not because of that. But issues 7, 8, 12, 13, and 15 really kind of all go together. And I just want to point out there are really kind of 3 main issues, or really especially 2 main issues, but the third being with I think Ms. Wilton and Mr. Green kind of really worked hard on putting together and incorporating all of these, 40, and that's why you see so many lines and mark throughs, is because they really wanted to simplify the language between 4507, 4509, 4511, 4501. That really has redundancies. And again, like Ms. Wilton said, this might not be the exact language that we can give up December 11th, but ideally, it is important to us to discuss removing the requirement for a PA to have an assigned locum tenens, versus just calling everyone a supervising physician. Also, we would like to certainly remove the performance plan that is overly burdensome and essentially is the same reflection, again, of clinical practice guidelines that are annually reviewed. And within those same rules is this weekly site visit that these SPs have to go find their PA and have a weekly site visit. So I know that Crystal might go ahead and let you guys know you already discussed the weekly site visit, and as a group, I think voted to remove that, and then as well as the performance plan. But when we did that along with those two, we were able to simplify the language. So for time's sake, and I really just want to make sure that we can remove the weekly site visit requirement, remove the performance plan requirement, because that is our clinical practice guidelines. And then lastly, remove requirement of a locum tenens physician requirement. So Crystal, however you want to start with that, and I don't know, Ms. Wilton, if you wanted to kind of speak to that, trying to consolidate it and how we can untangle these top three issues.
Right. Well, the committee previously voted to eliminate all three of those requirements. That was that delightful meeting where we had several votes that were tied, and just to get it off the table, one of the members changed their vote just so it could go to the board, leave the PA committee and go to the board as the recommendation. So those three matters as concepts have already been removed from the rules. The question was how to merge the remaining language in those various because there were some things that we all agreed still needed to be part of the rules, and the question was, once we took out the stuff that the committee already voted to recommend elimination of, how did we but put it all back together in a way that made sense, eliminated redundancies, eliminated any kind of what you all had identified as appearing to be, if not conflicting, then at least confusing. And so we worked on all that, and we came up with this mashup, which I think got us mostly there. Since that time, some other folks that have had the opportunity to review it, and I told this to Walt yesterday, have mentioned to me that maybe we got a little aggressive and we carved out some things that probably were serving a useful purpose and might continue to serve a useful purpose. But it wasn't the three main elements that have already been agreed to be eliminated. It was how we put it all back together once we gathered everything back up again of what was left. So that's the comment that I would make, that the board, the committee has already voted that those things will be eliminated. It's how we put the entire thing back together that still remains to be voted on, worked out, what have you.
Okay, thank you so much. That's all of my comments. And then I guess my question would be for, I guess, Dr. Collada and Ms. Patricia, is I don't know that before the December 11th LSBME meeting that you guys would have a comfort level of trying to put it all back together. Our intent, at least mine personally, didn't mean to have like you said, a big document like this with so many red lines, but I would 100% would like to present to the board to redline a weekly site visit, the performance plan, so I don't know, I guess, do you feel like there's any roadblocks with those three items with some of the folks that have weighed in between a few weeks ago to now?
Dr. Van?
I think that there are going to be some roadblocks and it can be solved. But first, let me explain why there's going to be some roadblocks. Because we still have the classic dyad to the monster group practice, and things in between. And so if you have a classic dyad, you have to address a locum tenens or somebody that's going to be available when that physician, supervising physician is not there. We want, initially, Ms. Wilton and I envisioned almost 3 sets of guidelines in these areas so that they could really be tailored to the dyad, the large group, and sort of the middle ground. I think the key is that we can't write a set of rules that doesn't allow, for example, and you talk about employment, if we have a set of rules that says there's nobody to supervise if the supervising physician gets run over by a truck or you know, is out on vacation or gets lost at sea on a fishing trip, how are you going to be employed? So I think the key here is you have to recognize the types of practice that exist in our state and write the rules for them. And I think they may be a little different for each group. But again, we hear what you're saying, and we don't disagree. In some areas, it needs to be streamlined. And in other areas, we need the security. I think the board's going to look for security. But Pat, you jump in if I'm stepping on parts of my anatomy.
No, I think that's right, and I think, but I also agree that I go back to my earlier statement to say just because we don't require something in the rules and such that it would be a violation not to have it doesn't mean that each individual employer-employee relationship can impose whatever additional requirements it wants. But in truth and in fact, the committee has already voted to eliminate the locum tenens requirement as currently written, to eliminate the use of the term, to eliminate, not to eliminate the concept that there needs to be backup supervision if the primary supervising physician isn't available. That's sort of a no-brainer and goes without saying, except that we have to say it somehow. The board already voted to say that in the current technology, the weekly visits, physical visits, are not required. I think there might be some folks who have a concern, not so much in the actual direct provider-patient relationships, but more in the sense of such as the urgent cares and so forth. How are they going to operate in terms of a supervising physician and then some kind of periodic review or evaluation? But I see no problem with letting the board know, again, they've already been told, frankly, that the committee voted to eliminate those requirements as presently written, and that the effort now is to pick up whatever remaining requirements that went along with those, any of those that are necessary for good medical care, proper patient care, and public safety, just to make sure that those were caught up and incorporated into the newly merged article. And I feel like we did a pretty good job. I've since been told that we might have overlooked a couple of things, and I feel like those could be discussed in December too, and let the board weigh in on what thoughts they have about that. Because at the end of the day, these are the recommendations, and so if the recommendation is to get rid of it, you've already voted on that. Then what goes in its place and how is it going to operate? Are things that we can continue to work on. But having an acknowledgement at the board meeting that they were eliminated, as recommended to be eliminated in their present form, I think is certainly fair and represents what we've done so far.
Patricia, is there a way to get to identify what issues there are with it before the meeting so we could try to prepare for it or rewrite, present alternatives?
Yeah, I mean, I think that's a good idea. I think we wanted to get advisory committee input and their sense of what some of these questions and concerns might be. And then I really think that we can have a roundtable and have Mariah and Berkeley and anybody else weigh in too. We just can't have a quorum of committee members, obviously, but we can expand the discussion to try and see if we come back with something that puts into place this concept. I think that would be very valuable.
Ms. Bowen?
Thank you. And my apologies. I'm getting the continuous notification that I have an unstable connection. So if I waver, that's what's happening. And I want to say thank you to both Dr. Collada and to Patricia, because they kind of expressed some of the concerns that we've had, which is that the document feels much more for a hospital-based PA or a facility-based PA, when I know that there are a lot of PAs who are looking to move into primary care, which may be a smaller practice. So there may be some nuances. But I did want to also ask the question, and I think it was in one of the parts that's got skipped over. And forgive me because I'm going between 3 different documents. But I think I found it in the new document on page 12, which is, if you go down that first column to the new section C, where it says that it's a physician's notice of intent to practice. Are we changing the burden from the physician assistant's notice of intent to practice to the physician? Was that just something that got lost in a copy paste moment somewhere?
They're both going to have to sign the document. They're both going to have to sign the document.
So if you look up at old number 3, A3, all supervising physicians are identified in the physician assistant's notice of intent to practice as provided in 1517. And then you come down to new section C, it changes it from the physician assistant's notice of intent to practice to the physician's notice of intent to practice. So it's just a little confused as to whether that was an intentional change or something that was overlooked.
Quite frankly, I did not participate in how that was changed, but the envisionment is once these rules are completed, there will be a single unified document that will actually be circulated to the appropriate people by DocuSign and email. And we're going to make this so much easier for everybody in terms of the document. But technically, you're correct. The intent to practice is the PA with the MD, but ultimately everybody signs it.
Okay.
Ms. Berkeley?
Thank you. And again, I think this is to Mariah's question. What we were trying to figure out based on the various iterations was, is it no longer the intent from either party to have the delineated partners? The notice of intent from the physician assistant would no longer delineate their supervising physicians. Only the supervising physician would delineate the PA. How do you envision that part working mechanically? We just couldn't figure out what we wanted to do.
Conceptually, what Ms. Wilton and I have been working on is, let's start with the dyad, the traditional dyad. That will continue to basically be the same. It'll be the one notice, one document. I'm going to be the supervising physician for PA so-and-so. PA so-and-so signs an agreement, that the doctor signs the agreement, and it's going to state in there that we'll have the necessary documentation as prescribed by the law and the rules available to the board when necessary. That's all we need for that. But let's take a large mega group where there may be, 15 internists. Let's take a little smaller. There may be 10 neurologists, okay? And there may be 14 neurology PAs. Right now, we have 10 times 14 documents that need to be signed and collected. We want to do away with that. What we want to do is say the chief of neurology will say, these are the PAs that will be operating under our clinical practice guidelines, and they will be defined as we see fit, okay? And these are the doctors on our staff who will serve as, quote, the supervising physicians in my absence. I, as the chief, am supervising physician for everybody. So that way we cover the call schedule, all of the people, it's going to be one document that may have, instead of 140 documents, it's going to have one document with 14 signatures. And it's all doable in the way we're going to do it by electronic means and
Hire one PA, and then there you go.
I'm sorry, what? Joe?
No, I'm sorry, I should have commented, but
if one PA decides to leave,
if I could, I would like to defer to Dr. Collada. There are a couple of things that I saw and that that he could share with the committee. The problem is eventually people leave and people come. So while I understand one document, if PAs leave, somewhere along they got to be unhooked, and then when people come, they're going to have to get rehooked. So one document's not going to work.
Well, Joe, the way we're going to do it is all electronic, and anytime that happens, the supervising physician can go to their portal in our website and disconnect that one PA. Al and I and IT are working that out, but we sort of put a stop on it until the rules is finished.
But is the rule change premature to that happening?
No, right now we're setting it up for just the current system, and we're going to make it work more efficiently for the bigger system once we get a bigger system imbued in the rules.
Sarah?
Sorry, again, I can't quite figure out how to do the cute emoji. So I just want to make sure that we're transparent about what we're trying to accomplish here, which is that we want to mimic the same requirements of nurse practitioners with collaborative physicians, that there is one supervising physician, one collaborative physician, and that is consistent with the statute, which is that the mechanism and method of supervision is defined at the practice level, and that the supervising physician and the PA must be able to be in contact with each other via telecommunication device at all times, and that supervision does not require the direct presence at all times of the physician. So, while there are efficiencies to be gained for sure by DocuSign and eliminating paper forms, the intention of LAPA here was to remove multiple legal requirements with multiple supervising physicians, equivalent to the relationship of a collaborative physician with a nurse practitioner. They are not required to have multiple collaborative physicians in large group practices either. So it's become very burdensome and really favors hiring practices for NPs because of this. This is probably, in all of the issues we're discussing, LAPA's the biggest issue. So I just want to make sure that everybody understands the rationale for what we're trying to accomplish here. It certainly, being able to submit electronically would be a huge improvement, but it was our intention and our rationale in reading the statute that really only one supervising physician is required by the law, and multiple supervising physicians is overly burdensome.
But the law does, the rules do require locum tenens, and we're doing this in lieu of a locum tenens.
Right. So to eliminate that, so essentially you would have your supervising physician that you're required to be able to contact via telecommunication device at all times.
But again, the chief may be out of town, and so whoever is on call for the Department of Neurology is the person that they would utilize. It sets up a hierarchical.
What if I don't work for the chief? I mean, what if my supervising physician is not the chief of neurology and is just a neurology attending?
You work for, what I'm saying is, the chief sets the policies for all of the people in the department. So the chief would say, these are the clinical practice guidelines for our PAs, and there's maybe two that do it differently. They'll do one, but then all of the doctors, whoever's on call in the absence of this chief, would be the person that you would go to at 3 o'clock in the morning on Saturday morning. That when you need somebody to help you, that's the goal of setting it up this way. Now, again, if you want to get away from that kind of supervision altogether, that's something that you can bring to the board, and the board will make the ultimate decision on. It's not, we're trying to address the concerns of authority and supervision in a way that is more efficient for the large groups, as well as still accomplishes what we need for the dyad. That's all.
Dr. Cresswell?
Yes, the only question that I had in this situation is, how would it work in, say, for example, a surgical practice? If you are a surgical group, you have 5 surgeons, you have 2 or 3 PAs, and you have one particular whoever the head of the group is as the supervising physician. If the PA is assisting one of the other physicians in that group and there's an issue, without that relationship or those clinical practice guidelines with the doctor who's actually operating at that time, there'd be an issue.
Well, that's why
And so-
we listed them all as part of the group, that everybody has to sign off on it. That's why
Right,
we
they
did
would
it
all
that way.
have to sign off on it.
Yeah,
That's
Okay.
exactly why we did it.
Right, a permissible delegation, and that's what we
Okay.
already have, so.
Okay, perfect. As long as it's that way, that it's different from the way it was proposed with the nurse practitioner, where you only have one physician as a clinical practice guideline. That's going to be a different situation than a PA working with a surgeon as a supervising physician. That's going to be a different situation. So you can't have apples and apples in that type of situation.
Yeah, and I haven't wanted to, because I'm afraid if I'm showing my ignorance, but I did not think it could be an actual translation that would seamlessly bridge the gap. But I totally understand the concept that they're espousing and that they want to work toward. And I certainly think, we just have to figure out a way to make it track in real life. I don't think the board, this is just my guess, but I don't think the board would want to do away with some line of authority, some tracking back to who was supervising at what time, at what day, where does the buck stop, et cetera. And that's the language that we were trying to figure out how to make it work so that the realities of day-to-day would be in sync with the needs of large administrations.
Okay, all right, thank you.
Are there any other questions or comments? Are there any public comments, Dr. Van?
1 second, and I will double check. No, ma'am, there are no public. Oh, wait, apparently somebody says, let me see when that came in. I apologize that the link's not working again. Hold on 1 minute. Let me double check.
I think that was earlier, Dr. Van.
Okay, so there's 4 now from Jeff. Okay, all right, got to know. That's fine.
Yeah,
There's
that
no
was
public
earlier.
comment at this time.
Given that we previously voted on deleting those 3, do we need to go ahead and have a second vote on those?
No, I think if I were in your shoes, what I would recommend is continuing to maintain the recommendation to eliminate the requirements as written, but request that everybody continue working on the replacement language in order to ensure that everyone's concerns are met.
So could we make a motion to keep with our previous vote and continue working on the language? Is that
Yes,
acceptable?
yeah, I don't think it's, yeah.
Ms. Berkeley?
If that is your motion, I'm sorry, I thought you were going to just continue to move forward. If you're going to keep with your your previous vote as a motion, that I just want, again, to be transparent, there is not one physician with whom I discussed these rules that did not have concerns about complete elimination of the performance plan. So to Mr. Green's earlier question about, can we figure out what those objections are? That would be one of them. And not to say that there aren't ways to alter the language to satisfy the parties. That's certainly plausible, but I just, again, wanted to register that concern before you voted.
Does anybody have any other comments?
My only comment would be if those physicians, I guess, really understood that the performance plan was not one and the same with the clinical practice guideline that also goes through annually reviewed with the PA and the SP, performance of patient care over the year, et cetera. That would be my only question.
And that sounds like something we can have further discussions about. As I say, if we invite Mariah and Berkeley to help us, make it to the finish line on this stuff, she can have a more fulsome discussion about what the concerns she's hearing, and y'all might be able to get to an agreement point, even if it's just some kind of, I'll just maybe call it prophylactic language. I mean, something that just gives a nod to the idea that, this or that can or should occur in some sort of scenario. I don't know what it would be, but that would be my thought, that it's something that possibly could be cured by some good language, and we just have to get fresh eyes on it to help Walt and myself figure out what that language should be.
Yes. Well, thank you all so much for having us on, and definitely appreciate all the work, Patricia and Walt, that you guys did to put us here. And we definitely look forward to working with our, physician groups and any other groups to kind of move this on.
Yeah. Sooner rather than later, for sure.
Yeah.
Dr. Van, do you have your hand up?
Yeah, I just had one question. Maybe if we were to use the definitional section and define clinical practice guidelines to include all of the things that Shelley, you seem to imbue into it, whether it's the annual evaluation, it's the privilege list, whatever it is, maybe that's the way to do it, to get everybody off of, trying to make sure we don't do something that they didn't want, but it encompasses what the board would want to see done. I think would you be comfortable with that? And number two, I asked Sarah to please send me the name of the consultant. I'll contact the consultant and talk about specific coding and issues, because that was one of my, how do I want to say, side hustles in my former years.
I'd be open to looking at it. And Dr. Collada, already it's written that the clinical practice guidelines are reviewed annually, and it also talks to several different things, but I guess we can look at it separately.
Yeah. Let's just try to play with the language to give everybody a comfort level.
Okay.
So can we vote? Can we have a motion to continue with our previous votes and move forward in adjusting the language here? Are there any committee members that would like to make a motion?
I move.
Is there a second?
A second.
All those in favor? Say
Aye.
Aye. Are there any opposed? Okay. All right. So I believe that concludes the rules and laws section of this meeting. And then after that, we have the PMP violation procedure. Is that right?
Larry, you want to address that?
Sure. Okay. So what we're going to request from the advisory committee is to kind of formalize what we've been doing for the physicians and others, prescribers, with the PAs as well. Because the law requires that any action that's taken has to come through the PA advisory committee first, we wanted to bring this to you. And I'll just kind of go through what we're doing. So the Board of Pharmacy puts together a list and sends it to us on a either semi-annually or every quarter basis. Sometimes it varies, of prescribers who are not compliant with the PMP law. And the PMP law specifically states that prior to issuing a prescription for CDS, specifically an opiate, in a quantity greater than 7 days, that the PMP must be checked. And if you are prescribing to this person for greater than 90 days, that the PMP must be checked at least every 90 days. Now, the law also specifically dictates what's to happen if one of the prescribers is not in compliance with the law and they're not checking the PMP. The law specifically states that if it's the first time this person's name is showing up on the Board of Pharmacy's list and then being referred to the board, then the board shall send a notification to the prescriber, letting them know that they are in violation, giving them a copy of the law and the rules, and encouraging them to follow the law and rules, but no action is to be taken. If the name shows up a second time on the Board of Pharmacy's list, then the board is to take some type of action. What my practice has been as the director of investigations is if someone shows up a second time, so it's a second timer on the PMP list, I will then have a formal meeting with that person. I will discuss the law and rules with them, get a written response from them as to why they're not in compliance, and then have a discussion to where we can ensure that they are in compliance, and then recommend what's called a letter of concern. Letter of concern is non-public, it's non-disciplinary, and really more of an internal document that shows that we had the conversation, we went over the laws and the rules, the board had this concern, but moving forward, we trust and expect that the licensee is going to follow the law and the rules, and we're not going to have this issue anymore. That's usually my recommendation. The second time, if the board approves it, we move forward. If they come back a third time, meaning that they are now this is now the third time that they're on the Board of Pharmacy's list, at that time, the board will then usually take some type of public action, whether it's a public reprimand or some other form of action, depending on how egregious it is. If it's 20 prescriptions versus 400 prescriptions. And so what we're seeking is the approval of the PA Advisory Committee for this process, so that we can do this process for the PAs without having to come back to you guys individually each time. Can you guys hear me?
Yes.
Okay.
Are there any questions about that? Would anybody like to make a motion to move forward with this process?
There is a 0.96 meter group of coarse heterogeneous calcification.
If anyone has any questions, just let me know. I'll be happy to answer any.
Okay. I guess do you need a vote from us for this or no?
Yes, I will need a vote and a vote from the advisory committee to approve us moving forward with that plan.
Would anybody on the committee like to offer a motion to approve this?
I move to approve.
Is there a second? Can I second it? I'll second it. All in favor? Say aye. Aye.
Aye.
Aye.
Are there any opposed? None opposed. Okay. And it says next meeting. Before we do the next meeting, do we need to do the executive session, or do you want to just schedule the next meeting now?
I think the next section, schedule your next meeting now, and then we'll go to the executive session and we'll excuse all of our guests.
I appreciate you guys. And again, if you have any questions, please don't hesitate to ask. Thank you.
Should we allow time for Miss Patricia to meet with Walt and the LAPA folks before we schedule the meeting? Or would you all like to go ahead and schedule it now?
I would schedule it now so that there's a fire under our rear ends to make sure we get it done before you meet again.
Given that we're going into December, does it make sense to wait until the first of the year? Or
Yes.
are we wanting to do this meeting as soon as possible?
I would no, because we can't get it to the board.
Okay.
So after the first of the year is totally fine.
Okay. Does a Tuesday work for everyone?
Works for me.
What about the second Tuesday of January at 3 p.m.? And if anyone has any other suggestions, we are open to them.
Thursdays happen to work better for me for my clinical schedule.
All right. Is there any objection to Thursdays?
Thursdays are fine.
Dr. Craven, Dr. Nikolic, Varsha?
Yes. Thursdays are fine.
I don't know if Dr. Craven is still there or not.
So would you be talking about Thursday the 11th or Thursday the 4th?
Probably let's do Thursday the 11th, so you're completely out of
Yeah, but I'll be out of the country in the 4th.
All right, that's fine. Let me double check the schedule. Hold on a minute.
Thursday the 11th at 3 p.m. we are available.
I can do Thursday the 11th in the afternoon.
All right, it's a deal.
Sounds good to me.
All right, perfect. I believe we can now move into the executive session.
Thank you.
So if I'd ask all of our guests, appreciate all your attendance, but if you'd leave the meeting now, we'd appreciate it because we don't want to have to cut you off. Well, okay, I think we got everybody here that needs to be here. Crystal and Raven and Miss Farsha, the two members of the physician members. So let me go ahead and pull up.
Wait a second. We're still
Wait,
live.
hold on. Yeah.
They need to vote to go into.
You need to
Okay.
vote to go into executive session, and we need to turn off the YouTube or
Can I have
pause it.
a motion to go into executive session?
We can go to executive room. We can translate. At this point, we'll move to executive session if you pass the motion.
I move that we go to executive session.
Is there a second? I'll second it. All in favor? Say
Aye.
aye. Aye. Are there any opposed? All right.
All right. And now you just click on join and we'll go to the
Tracy, I'm going to leave you in public session.
All right. After discussing file number 2023-I-59, we've agreed to, I motion to agree with the recommendations of the investigative officer.
Is there a second?
Second.
All in favor say aye.
Aye.
Are there any opposed? Okay. Are there any other matters that we need to discuss?
Let me just double check and make sure there's no other public comment, and we will be out of here for you and out of your hair. And there is no other public comment.
I believe we need a motion to adjourn.
Motion to adjourn.
Second.
All in favor say aye.
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 All right.
Aye.
Well,
Thank you, everyone.
thanks everybody for all the hard
everyone.
work today.
Thank you.
Bye.
Bye.
Good job.